Morning, everyone. We're just going to give it a minute or two to let people get into the meeting, and then we'll get started. And it looks like participants entering the room has slowed down. So maybe we'll just give it one more minute just to make sure. There's one more. We'll give it one more minute to see if we get a few more participants. Okay. So I think we'll go ahead and get morning, everyone. Just looking to Elisa. Are we good to go? Yeah, okay, good. Thanks for the thumbs up. So welcome. This morning we are going to have a COVID-19 update from Dr. Newell. We're going to talk about equity and have a presentation and then some breakout discussion groups. We'll have a report out facilitated by HIP staff, and then we'll close out the meeting. And before I transition over to Elisa and the HIP team to give us some announcements, I just wanted to thank people for their time and attention. I've just been reflecting on the value of leadership in this really chaotic time, and I'm really grateful and appreciative of the commitment that healthcare leaders in Santa Cruz County have to meeting on a monthly basis to talk about what's happening in our community and to work towards alignment as we think about how to best serve the people of our community. So I just wanted to start out the meeting today with an appreciation and some gratitude for all of you and your commitment and really making time when things are so busy and hectic throughout the day. So thanks for indulging me in that. And I will turn it over to Elisa to share some HIP announcements.
Thank you so much, Stephanie, for those encouraging words. And I think my first announcement really builds on the importance of collaboration, because especially in these times where we're all facing, just unprecedented situations and having to approach our work in different ways. We here locally have found a great synergy with Dientes. HIP is now sharing office space at Dientes Administrative Office. HIP staff is coming into Dientes Tuesdays and Thursdays. So we have the office space to ourselves on those days. And the admin staff of Dientes come in on Monday, Wednesday, and Friday. So we've officially moved in, and we're very excited for this partnership. We really think it leverages resources that are scarce in these times, and it provides us with more opportunity to work with Dientes and to build our partnership. And so we're just really excited to be announcing that to all of you. And although it's not possible at this time to have a grand opening or to invite you all to see how we're sharing the space, we hope that in the future that will be a possibility. But for now, just know we're very happily now working out of Dientes Administrative Office. I'll pass it over, I think, to Shelly for the next announcement.
Yeah, I am really excited to share and ask for your help in us recruiting some talent. HIP is hiring for 2 program coordinators. One will be focused on population health and the other on care coordination and our healthcare team provider trainings. So those job descriptions and snippets are on our website, and please share widely and spread the word so we can recruit swiftly and add to our team. Thanks.
Good morning, everyone. I'm Amy, HIP's program assistant, and I would like to invite you all to our upcoming continuing medical education event on Thursday, October 29th from 7:30 a.m. to 9 a.m. This event is titled Racism in Healthcare, Confronting Chronic Stress and Chronic Disease. And I can go to the next slide. And so we're proud to announce that our keynote speaker is Dr. Raymond Flesch, and we engaged with Dr. Raymond Flesch a few months back at HIPC during her presentation on racism and xenophobia, impact on youth and the providers who serve them. And so the learning objectives for this convening are to define internalized person-mediated and institutional racism, identify ways that racism and xenophobia can impact the health and well-being of immigrants in California, recognize opportunities for addressing racism and xenophobia in medical settings, including patients and providers, and lastly, define ACEs, adverse childhood events, and their impact on chronic disease. And so this talk will acknowledge racism in society and healthcare and connect their impacts on ACEs, toxic and chronic stress, chronic disease, and trauma, as they're all connected. And so we have secured CME credits from AFP and CE credits for behavioral health from CAMP through Santa Cruz County Human Services Department. And we currently have CEs pending for RNs. And yeah, the planning committee and I welcome any questions. If you have any, please send them in. And then I'm also sending the registration link in the chat right now if you all would like to register and help us spread the word for this event. Thank you.
All right, thank you. So now we have 5 minutes, and so I'm going to hold us to it because we have a full agenda. So we're going to go till 7:44. If there's any partner announcements, please raise your hand, and then you'll be called on to share. And remember to unmute yourself when it's your turn. Do we have any announcements? It looks like DeAndre.
Can you hear me?
Yes, we can.
Morning, everyone. Just a quick announcement on the Health Trust. A couple of things. Just if you didn't know, we are the ones that are administering the CARES Grant Act in regards to messaging. The deadline for applying for those funds or this on the 9th. And so if you haven't had an opportunity to apply for those funds in regards to messaging for COVID-19, please do so. The funds, yes, the funds are directed mostly towards the South County because of that's where a lot of the COVID cases are, but the funds are open up into the entire county. So if you haven't had an opportunity to do so, please do. And then on a more fun note, we do have the Wine and Roses event. Please, if you're not planning, the event itself is free, so you can come and join the event. But I would suggest you want to get the wine to go with the event. And so the fun thing about the wine that goes with the event is whatever wine organization you chose to get wine from, their sommelier or owner will be on there on our at our event, actually talking about the actual wine. So that's kind of a fun thing to do, to have wine and have it kind of education about the wine. So anyway, those are things I just want to pass on. But please, the CARES Act is money is out there, and I want to make sure that people have opportunity to get it. And also, just the wine and rose event is just a fun event. So thank you.
Thank you. Okay, I'm not seeing any other hands raised. And I think we have time for one more announcement, but if we don't have one, then we can move on to our next item on our agenda. And so I will hand it over to Gail, who's going to give us the COVID-19 update.
Good morning, everybody. I will echo Stephanie's words and thank you all for your excellent partnership and leadership during this ongoing, lengthy, difficult work that we're doing during this time of COVID and fires, entering flu season, and fire recovery. So I'm gonna zip through some data as usual. I'm very excited about the equity theme of today's meeting, and it fits perfectly with what's happening in our world because the governor has just announced a new equity metric that will be part of our scoring for our tiering for economic recovery. So let's quickly zip through the data. The big change you'll notice on our front-facing page at santacruzhealth.org is that we now have a significant number of new deaths. About 2 weeks ago, we were at 10, where we had been for a while, and we have had a rapid increase in deaths, largely due to an outbreak at Watsonville Post-Acute Center, which is one of our 7 skilled nursing facilities in the county of Santa Cruz. We've had a heartbreaking outbreak there. It happened very quickly. About almost 70% of the residents became infected with COVID in a very short time period before we could really even institute any disease control measures, further disease control measures. And we expect some more deaths from there as well. Things are getting better under control there. And it wasn't any wrongdoing on the part of anybody's there. We just know that these are super vulnerable populations, as we've seen in other communities around our country and around the world. And the disease can spread very quickly and lead to lots of death. So this is what we've been working very hard to prevent, but unfortunately, we've now experienced it ourselves as the community. Otherwise, we're in a very stable position. You can see from the blue bars on this epidemic curve that we had a bump probably from Labor Day gatherings, the fire and household mixing that caused. But it seems that we're headed still on an overall downward curve, as is the rest of the state of California at this point. And we'll get a little more into that, but next slide. I want to encourage all of you who haven't been to our newly interactive website in the past month to go to santacruzhealth.org, and you'll find that you can get a lot of information by moving your cursor around over these pages, and it's really interesting to look at the data in that way. I can't do that for you today on these static slides. You'll see that on the age breakdown and that our 20 to 34 year age group is slowing down a little bit in proportion to the rest of the ages in the case range. So perhaps some of our outreach to them has been working. And next slide. Our distribution, and again, if you use the website interactively, you can roll your cursor over these different areas and see which is most impacted. But no surprise, it's still mostly the Watsonville area, mostly the Latinx population. And you can see our case numbers and percentages broken down by city, unincorporated areas in the county, etc. And next slide. This is our equity view. And most remarkable is that in the lower left-hand quadrant, and that's known cases by race and ethnicity. And the short vertical lines are where we would expect the bar to fall based on the proportion of population. So you can see, for example, in our Latinx population, the gray bar, we would expect the percentage of cases to be at about 33%. 1/3 of our county is Hispanic Latinx. But instead it's almost 2/3 that are impacted by COVID infection. And then the same with South County in the lower right-hand column, where even more impacted, more disproportionate, more than double the amount of expected cases in South County. And next slide. Here's our hospitalization curve. We've had a lot of variability, largely due to this skilled nursing facility outbreak, so the model isn't as predictive right now. So we're only using it for 2 weeks out because of the large confidence interval deviation when we go further. And next slide. We still continue to have a concerningly high reproductive number. So we want to be down in the green where we were April through June and not up in the yellow. But we've been there for about the last 6 weeks, and that shows disease activity in our community. We're hoping that this calms down a little bit because right now our reproductive number, which is the amount of disease spread happening in our community, is on the high side. And next slide. This is the breakdown of the epidemic curve by race and ethnicity, and largely driven by the Hispanic Latinx population, which is the dark blue or purplish kind of color. And this follows our own epidemic curve very closely. And next slide. This is our comparison, and you can see that we're clustered along with the other Bay Area counties, but still relatively low compared to other counties in California in terms of our case rate. And next slide. So what we're doing locally, we're continuing to support the Watsonville Post-Acute Center with our multiple teams. They are being staffed mostly by the California National Guard at this point, but we're working with the State of California licensing arm and California Department of Public Health to do some additional staffing, working with their corporate owners. Working with the twindemic to prevent a twindemic in our community of seasonal flu and COVID-19. We're continuing our work with local schools on COVID-19 strategies. There are 14 private schools that have opened in Santa Cruz County now, and I know we've had at least one case in a student that our communicable disease unit is working on, but no significant outbreaks in the schools at this point. The public schools are starting to make plans. Some of them will open later this fall, hopefully. Others have committed to staying closed through the calendar year, but hope to open in January for classroom learning. And then we're excited to announce that we are incorporating an equity officer team into our incident command structure in our Department Operations Center responding to COVID. And the equity concept it's been a core value and embedded into our objectives from the beginning of our COVID response in March, but we're operationalizing that now with an equity officer team. And next slide. We now have 19 local COVID-19 test locations, including many walk-in testing options through local pharmacies. The OptumServe site is still up and running, and we have a current testing capacity of 500 to 600, and actually it's probably quite a bit higher than that because Santa Cruz, UC Santa Cruz is now able to surge up to 500 tests per day, 5 days per week. Next slide. And a reminder that it's more important than ever before to get your flu vaccine this year, so we don't have symptoms confusing us between flu and COVID-19, impacting our healthcare system. I did issue my usual annual order for mandatory implementation of influenza vaccine among healthcare workers in all healthcare facilities. And next slide. So the state has, as I mentioned earlier, has widened their criteria for the blueprint for a safer economy. So not just test positivity and case rate now, but the health equity metric as well. Next slide, please. This is what you've been used to seeing. We started in the purple widespread segment and are now in substantial, where we've been for about a month. And we are squarely and firmly in substantial right now with a dropping case rate, as I mentioned. And let's go to the next slide. So here's the state of California, a significantly lower overall case rate and a lower positivity rate, and many more counties in the orange and yellow and red like we are, and fewer in the purple. That's all a good sign. And next slide. Santa Cruz itself has a 5.9 case rate, adjusted case rate, and that's squarely in the red here. So we're safely there for at least another 2 weeks, probably longer, and a low positivity rate overall at 3.2. Next slide. So the new equity metric reflects the statewide effort to include all Californians in all communities, especially those most at risk, which are communities of color. Next slide. And the equity metric is a way to ensure that counties with lower disparities, and ours is in that mix, move quickly through colored tiers, and counties with larger disparities move more slowly. And next slide. So what's being used is the Healthy Places Index. This is an index about socioeconomic status that's used for a variety of different measures. And it's divided by census tract or health services tracts. But for this measure, this metric, we're using census tracts. And we're using the lowest quartile of our census tracts. So in this map, excuse me, in this map, it's dark blue is the lowest quartile, light blue is the third quartile, light green is the second quartile, and the highest HPI, highest socioeconomic status is dark green. Next slide. The benefit of using this instead of just a single measure is that it's granular. We can look by census tract. It's policy solutions focused. So the Health Policy Index platform has policy solutions for each of its 25 indicators. And it includes important health outcomes such as life expectancy at birth. And next slide. This is an example of how we can use Healthy Persons Index to look at various communities and their disparities. And in the case that that the state chose for this presentation, which is median household income compared to COVID-19 rates, you can see that the communities of California vary widely, but that Santa Cruz in particular has a very good response with less disparity in our COVID-19 rates. And next slide. This is our map for the week, and we get a map from the state now every week on Tuesdays, which we call Tier Tuesday. We get all of our measurements, and you can see the dark blue areas are the bottom 25 percentile for Healthy Places indexes, so mostly in Watsonville, but also it looks to me like maybe Beach Flats and maybe Live Oak, I'm guessing, some of those areas that might be in our bottom 25 percentile. And next slide. So you can see the purple, red, and orange lines, and both of our indices are in the orange section below the red line. So the dark blue line is our lowest Healthy Places Index quartile of people and their test positivity. And then the dashed line is the total overall county. So the state will be weekly comparing those two measures. Ours are both in the orange tier, which means that potentially we could more quickly move from red to orange. Next slide. The second component of the equity metric on which the state will determine is something like this, and I don't expect you to see all the details, but it's a plan that we will be required to submit on a monthly basis. Our first one is due on October 15th, and it asks us to show how our funds and our other resources will be distributed specifically to those dark blue areas and the populations that live there, how we are addressing the inequities in our community. And at the very least, the state is expecting that we divert our funds and our resources equitably according to COVID-19 rates. So for example, they want to see that 2/3 of our money is going to our Latinx population, our money and our resources in our COVID response, because that's our COVID rate in that population. And next slide. Just a reminder of the basics. Continue to do your individual behaviors, because what makes the biggest difference in our community's outcome overall. And remember to get your flu shot. And next slide. I'm happy to answer questions. And again, thank you for all of your hard work.
So Dr. Newell, we had one question in the comment box, which is, how do things look for the county skilled nursing facilities, including Watsonville skilled nursing facility? And then if others use the raise hand function, we can try to facilitate those questions.
And I apologize for my snoring dog beside me. That is not me making those growling noises. The other skilled nursing facilities, we have not had any large outbreaks like Watsonville post-acute until now. We have 7 skilled nursing facilities overall. All 7 have had an outbreak at one point or another. And let me describe that further. An outbreak in a skilled nursing facility is any one case or positive test in any one resident or staff. So it's very easy to have an outbreak in a skilled nursing facility with that definition. That's a nationwide definition, and that's because we want to respond very quickly to any case at all in a skilled nursing facility. In each case that we've had an outbreak, our team has been able to get in there quickly, do rapid testing and turnaround, and ensure that we're isolating folks who test positive and quarantining the others who have been exposed. And that's been a very effective measure until this one.
We have one more question. Sorry, I'm trying to grab it. What type of proof will be needed for our facilities for the flu shots?
Say it again. I'm sorry, the flu shots and...
Yeah, what type of proof would be needed for facilities for the mandatory flu shots for healthcare workers? I think that's what that refers to.
This is the same order that everyone has had every year for flu season in the county of Santa Cruz and most of the state of California as well. So whatever your personnel department or occupational health department uses, mostly an employee would need to either receive a flu shot on site or bring in some kind of verification that they've had that elsewhere.
And then Larry had entered a question. Do you want to unmute yourself and talk, Larry, or do you want me to read it?
I see the question in the chat. Okay. And you can go to HPI or Healthy Places Index and Google it. I did that last night. And you can see those maps by index measurement and quartiles in a variety of different ways. You can do it by congressional districts or census tracts or by county. You can look over the entire state. It's really interesting. So just Google HPI or Healthy Places Index, And there's lots of different maps there that you can explore how those are scored, and lots of details about how that's done.
There are some additional questions in the chat. And maybe if we just take the two that are remaining there.
There's Jack.
Little bright moments are good. There's a question about, is the county able to acquire additional vaccines? We placed our flu order pre-pandemic. And so is there an opportunity for the county to obtain additional vaccines?
That's a question that I'll have to get back to whoever asked that on.
It was Anita from Salud.
Okay.
And then DeAndre asks whether Community Health Trust or other health agencies can help give out flu shots.
Flu shots are available, I believe, through all of the safety net clinics, through almost every pharmacy, even folks who pay out of pocket. The cost is only about $15 is my understanding. So as my understanding is that they're widely available throughout the community at this time.
Okay.
But if there's others like Salud who need additional vaccine, please reach out to Public Health and we will get back to you on that.
Okay. We are at time for this item. I don't see additional hands raised. So thank you so much for your presentation and for the rapid fire questions. I see a comment that vaccines are available and there's mobile options for large clinics, but perhaps we share information out after the meeting so we can connect on that. But I am going to move us to the next topic. So thank you very much.
Thank you all again.
So next up on the agenda is Shelley Barker, so I'll hand it off.
Thank you. So I wanted to just frame this in the sense of, and I was confident that the seg between Dr. Newell and I would be really tight, as it obviously is. Because I've been so pleased with the leadership from our public health officials around equity. So the intention of this portion of the agenda is really to do this, to put a spotlight on equity and for the HIP Council to engage with this topic, because I would assert that anything that is really meritorious is often a little bit vulnerable. So our goal with this is to acknowledging that 2020 has brought so many opportunities for we as human beings and leaders, especially in healthcare or any social service organization, to dig deep and be our best selves and our most courageous leaders. We felt like it was appropriate to offer an example of really some difficult and vulnerable interactions that the SafeRx team has chosen to dig deep into. And then as you've seen in the rest of the agenda, then we'll be breaking into small groups with facilitators delving into some questions that will allow us in small groups in hopefully fairly safe feeling setting to practice having some of these challenging conversations. And I just want to, I feel like it really builds so beautifully on hearing Dr. Raymond Flesch and what I thought were some really key definitions that can help us engage in meaningful conversations around equity, as well as last month's really heartfelt, honest expressions of where our HIP Council organizations are at and personalities as leaders. So without further ado, since there are a few new HIP Council members, I wanted to spend just a very brief moment introducing SafeRx. So SafeRx is our local opioid safety coalition. This is the coalition structure. I'm mindful that the font is small. And go ahead, next slide. What we wanted to share is just a quick snippet of some accomplishments. SafeRx was begun in 2015. We've had really beautiful multi-sector collaboration, and I want to say that as we describe the accomplishments, this is by no means Rita, Shelley, Jen accomplishments. This is our community coming together around a complex and troubling issue of substance use in our community. So one thing that we've worked on recently is really in empathy enhancement. And I think maybe there's an animation, because there should be, there we go, thanks. So we have worked on developing materials in various ways, and then also recently had the opportunity to partner with Pajaro Valley Prevention and Student Assistance to deploy promotoras in South County to share some of these resources and actually get feedback around the development of them. Go ahead, next slide. And then also, thanks to lots of different reasons, including Dr. Newell's leadership and connections in San Benito, as well as some statewide interactions that the HIP team has had the pleasure of engaging in with some supports from the Center for Care Innovation and from the COSIN, an accelerator group of accelerating cross-germination between regional opioid safety groups. We have really pivoted to a tri-county effort for some of these layers of our work. So medication-assisted treatment, as you all remember in 2016, we launched this concept of breaking bread to break barriers to increase the number and confidence of ex-waivered physicians. There's been a lot of deep, rich work recently with both local large hospitals around MAT in the ED setting. Huge progress recently with MAT in jails. And then also responding to data, we have started convening folks to talk about as a polysubstance work group, because we understand that stimulants are really a challenge in our community. It's not just opioids. So, and then lastly, we also, and they're on HIP's website, but we have pain management guidelines, which were collaboratively produced with multidisciplinary team and offer prescribers guidance as to, you know, really for chronic pain, opioids are probably not the answer, as Big Pharma's led us to believe in the 90s. So I will pass to my colleagues now. And before I pass the baton, I just want to say that, again, as you listen to this story, our intention is to share our own experience in engaging in conversations in which we felt vulnerable in our work, and we realized that the situation was calling us to respond differently than we had in the past. And so this description is you know, just a quick description of our journey as a team to more meaningfully, deeply, authentically engage people with lived and living experience. We thought we were doing it. Our intention has always been there, but we received some feedback. So I'll pass it to my colleagues now. Thanks.
Thanks, Shelley. That's great. So here's a photo of some of our Harm Reduction Coalition volunteers who have been working hard for many years. And we've been, or as Shelley's going to say, we thought we'd been collaborative with Harm Reduction Coalition and since our inception in 2015. And as a reminder, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And we're, you know, we all are very much in alignment with that. But it was when we went to a kind of workshop setting through an opportunity through the Center for Care Innovations, or CCI, when we brought our, two of our harm reduction colleagues came with us, Kate and Danny, and we were tasked with identifying a problem to address and to develop a prototype to solve that problem. And as we were in the room together, next slide, Rita and I in particular, and definitely, you know, noting the interactions with our harm reduction colleagues, we saw that we really were operating with profoundly different paradigms and that we had profound points of disconnect. And so we want to name those. And the most obvious one was an orientation towards drug use. And we realized, Rita and I, at that moment, that we didn't really understand harm reduction. And that, that even though we thought we were really aligned towards safer drug use, that for us, not using drugs was really the ultimate goal. And that is not the ultimate goal. of harm reduction. And this became apparent in language. We thought we were using human-centered language, but we got feedback that we were not. And it was hard for our colleagues to be in the room with us. We also identified a core difference in, for example, the inclusion of law enforcement. That was very important for us. But having had negative experience and stigmatizing experience, our harm reduction folks were not so sure. That made them afraid. Next slide. And so with this prototype in front of us, really what we wanted to do shifted. So instead of had a different sort of goal for this project with CCI, we began to work on this being our problem. And so we moved into a kind of a soul-searching place, looking at our language, thinking about the term stigma, which actually didn't land for them, and we pivoted to empathy enhancing as our focus. We sought feedback from folks with living and lived experience and began a process of very deep one-on-one conversations with harm reduction folks and others for direct feedback. And Shelley has already used the word vulnerable, but truly it was a kind of shift in orientation and coming into alignment. And so part of our prototype was to create a core leadership team, including people with lived experience. And that's kind of part of what came out of this experience. So the next slide, so that we could have move to streamline decision-making with the people who were being impacted by our work. So there's a phrase, nothing about us without us. And I should have added that little image. Next slide, moving, yeah. But developing content that actually lands for the people who are receiving your materials is critical. And again, our solution was to create this core leadership team, which we'll talk about more later. Next slide. This is the word cloud that came of our first meeting when we sort of brought forward this solution of really being more inclusive. As you know, a word cloud, the words get larger, the more people who write that word themselves. It's kind of unprompted. And so you see that if we didn't move forward with integrating harm reduction with us in our process, these are the concepts that folks shared. Next slide. And so we also wanted to share some reflection that stigma is pretty alive and well, in Santa Cruz County, in our emergency rooms, in our clinics. I went to the ER for an abscess that became unbearable. And after disclosing my history of drug use, the nurses and doctors quickly changed how they treated me. I told the doctor that it hurt when he wiped the abscess, and after a glance at my track marks, he said, "You should be used to it." Next slide. And we hear this a lot, unfortunately. So our work became this. How do we engage the voices of those with lived and living experience with empathy enhancing approaches? To you, Rita.
Thanks, Jen, for framing that for us. So as Jen mentioned, we decided to do a prototype for our Center for Care Innovations project to create a polysubstance work group, as this was kind of an emerging trend in our community. And we had heard that throughout our program processes with the Harm Reduction Coalition. We actually pivoted during the middle of our project to focus on this because they felt it was so important, as did we. And so when we were creating this work group, we looked at member orientation. So who are we inviting to this group? And then once we did that, reevaluating, asking people, are we missing someone? Do you think some group should not be here? And then we held our first meeting, I think it was the last day before COVID hit, and I'm still in awe that we met that fateful March afternoon. But it was a great meeting, and we've met quarterly ever since and have done some great content development. And through that process, we've held focus groups with people who use, that are polysubstance users, and particularly we've been focusing on people using methamphetamine. And so we were able to garner feedback, and I'll show you some examples of what we've created. And then it's going to be a continued iterative process. So we want to make sure that our content is simple, easily changeable, print friendly, so that we can keep including the feedback from them. Okay, and here is an example. So this is the most recent document that we created with this group. And so it's a meth help card. And so we were able to have kind of focus groups and interview people who use methamphetamine and say, hey, what kind of language resonates most with you? Does this look simple enough? Or is the language, appropriate for the lay person? Should we need more color or imagery and whatnot? And so this is our newest Mat for Math, basically, card, and we've been working with the county very closely in their programs, and now it's, as you can see, it's moved beyond. And so this is just a good example of how we can continue to make changes and easily update phone numbers and things like that. And another really exciting project that SaferX has been working on is, as Shelly mentioned, with the promotores at PVPSA. And so we were focusing on communities of color and that are being heavily impacted by substance use disorder. And so we wanted to, again, keep this theme of empathy enhancing and equity in our work. And so we were able to interview before COVID, have a few in-person trainings with promotores, and then we've held since then some virtual focus groups with the promotores to ensure that this educational material that we developed was culturally appropriate. It translated well to Spanish, because oftentimes that doesn't land so well, just translating. And so this is just one example, and I'll show you a few. So no more stigma, no more shame. The opposite of addiction is not sobriety. The opposite of addiction is connection. And overdose can affect anyone. So these are all materials that we've been giving out, and PVPSA has done an incredible job with their food pantry services during COVID, and so they were able to actually reach people still in person. And we've reached about over 1,000 people, I think, with these materials and other MAT availability and Narcan options. And so as we were working through our polysubstance work group, it kind of came about, how can we move beyond this prototype? How can we push forward and elevate the work we're doing? And so we collectively decided to develop a core leadership team, as we mentioned earlier in the presentation. And so this leadership team is really, I can show the next slide. Sorry, it's kind of small font, but you can get the gist of it. We wanted this to be a really core small team that can streamline decision making for us, so Shelly, Jen, and myself didn't feel kind of the onus on us for making all these, oh, we want to focus on youth, or oh, we can sign this letter. We wanted to really have a collective decision making process with our coalition, but not have to send it out to the 100+ distribution list and hope someone called back. So there's about 6 of us on this team, and we really were strategic in asking different multi-sector representation, and that's where we had members of harm reduction and people with lived or living experience on this core leadership team. And so we've met a few times, and we were able to put this into implementation, signing on letters, op-eds, things like that. And it's been a process for me, and I really have enjoyed it. Like Jen mentioned, having those vulnerable and difficult conversations. I had to stop and think, why was I so offended when they said they just want safe drug use? It really brought something out of me. And so that's been a self-reflection process. And I've come to the terms that it's okay that we don't 100% align, but it's important that we have that dialogue. And I think from my perspective, the harm reduction members feel the same way. They've reflected back to me that they appreciate those conversations, and we still collaborate really well together. And I think you kind of need those different ends in the harm reduction field. So this is a core leadership team. And we just love this image. We wanted to end on this image. This was from International Overdose Awareness Day, which hopefully some of you were able to attend. Gail spoke and facilitated and did an incredible job. We had Melissa Etheridge sing a song. So I have that recording if anyone's interested in hearing kind of how we elevated people's lived experience in that and presented. And we can share that in the follow-up, and that's it. So thank you, and I will pivot back to my team for breakout sessions.
If there's any burning questions, feel free to chat those, but we do want to maximize time for small group interactions. And the plan, so let me just run through the plan and remind us of the intention. So again, the goal is with this concept of spotlight on equity, we want to offer opportunities for colleagues at HIP Council to interact in these ways. And so the intention with the questions is that we want each small group with a facilitator to think about a pain point recently where you realize that what you're doing is maybe missing at least one really important perspective of your constituency, your client, your patient voice, and then think about what we could do differently. And I just want, as we pivot to that, I wanted to remind you all of that word cloud, and that when we said what would happen if we continued to proceed in the way we have in the past in our coalition work. And it was really clear that those unfortunate words that we quickly populated, we didn't want. So it helped us to dig more deeply. And so that's my sort of call to action to you as we pivot to breakout sessions, is think about that in regard to, it's almost like a motivational interviewing principle of, you know, anytime that we're engaging in behavior change, and I would say that behavior change in this instance is approaching our work differently. There's this important level of exploring one's own ambivalence, right? Because if it was easy to make a behavior change, we would have already done it, right? so that exploration of our ambivalence, on the one hand, there's merit in looking at what would be the consequences if we didn't change the way we're thinking or doing. And so I just will express that for my personal journey in this SafeRx example, that word cloud was a moment where it just hit and it landed, and it was an aha moment for me. And that's what we hope will be able to happen for small groups in this moment now. Okay, so we'll have about 30 minutes, and again, there will be a HIP facilitator, and the intention is that these questions will be in the chat box so that you have them in front of you as well. And I think that covers it. So, the other thing I'll say is that the facilitator will report back. So please don't feel like you need to hold back if there's something that is a little bit vulnerable. You can say that in your small group if you feel comfortable, and it doesn't need to be shared back to the whole HIP Council. Okay, without further ado, I will let my colleagues break us into breakout rooms. And I think we're all landing, and I think I am expected to make this seg too, and lead us off with a brief sharing of our rich discussions. So I had the pleasure of interacting with Stephanie Sonnenschein, Dale Bishop from the Alliance, and Gloria Reed from Hospice, and Marcus Pimentel from HSA. And some of the themes that came forward were the real need for, as we just acknowledging that our healthcare delivery system was not developed with the patient or client's needs at the center, right? It's a sick care system, and there's all kinds of efforts to shift that, but it's shifting. I always have the image of it's shifting a barge in the water. So while the patient voice is incredibly important, there's this misfit with the system design. And so there's definitely a need to elevate the client voice, and that there are some best practices in terms of case management, and then also the importance of developing trust, and also having the workforce be culturally competent. And of course, there are some challenges with that takes time as well to really shift a workforce in any organization to be able to offer the kind of care that we all want to offer. I think those are the key points. It was rich discussion about how to elevate the patient voice, and perhaps capturing, addressing, and then documenting across time what the patient wants or the client wants is one salient short-term step. So I can see Jen's face. Jen, do you want to share next?
Sure. Oops. Can you hear me okay? I may be echoing here. So, Okay, I'm sorry. I'm going to have to turn this off. Okay, so we, let's see, Larry Digataldi, Anita from Salud, Stephanie, and Philippa Barron were we were in a group together. And we, I think, kept going back to how COVID has really laid bare the inequities and the kind of the structure we have for providing healthcare in this country and in our community. Just, it's terrifying, actually, and that we're not serving the people who need care, and that it's not accessible or affordable. And so we focus less, I think, on the voice and more on just how we have failed in terms of serving those who have, well, who are the most in need. So I'm afraid we didn't get to the positive, the benefit of the voice, because they're not being served. We had Anita shared some extraordinary work that has been done at Salud in terms of providing recognizing that folks were not on their medications and getting access to medications through direct relief and really reaching out in an extraordinary way. But I'm afraid that we did had a rich discussion on the lack of access to care. So I'll pivot to one of the other leaders, Elisa or Rita.
I can go. Oh, are you going, Lisa? I can't see all the faces right now.
ahead,
I can go. Okay, thanks. So I had the pleasure of speaking with Gail New from County HSA, DeAndre James from the Trust, and Amber Williams from Janus, and we had a really rich discussion, I think, and kind of echoing what Shelley was mentioning earlier is that there's kind of a consensus is we don't look like the community we're serving, and how can we bring the people that we're serving to more leadership positions, and if that's not totally possible, how do we make sure that their voices are included at the higher level? And similarly, having a workforce be more culturally competent. And I thought a really important point that Amber brought up was not only just the staff being culturally competent, but the processes of how you engage someone from a different culture, from beginning to end. Kind of looking at, we're talking about an example of intake, through the process of, for example, giving birth and the cultural things that go around that. So I thought that was really interesting. And then I was writing it, we had so many good quotes. So a few that I really enjoyed were that community members wouldn't be aware or access resources. And that's, the whole point of so many of our organizations. And so that would be a huge challenge or loss for our community. And then another one was, if we can't relate to people, we lose connection. And if we lose connection, we have less of an impact. And I think that's, again, the whole point is we're trying to serve our community and create more impact and keep that trust. Failing to act, we lose trust, we lose everything. So how do we keep these patients and clients involved and feeling safe to connect with us so that we have that trust with one another? And the last thing I think that was really helpful for me was the benefits question. What do you anticipate in confronting these challenges? DeAndre was mentioning open as many doors and as many opportunities. And I thought that was so well said is, he brought up the example of SafeRx. We had one door of, kind of this idea of sobriety and you need to stop drug use. Whereas now there's another door open for, okay, do you want safer drug use? So how can we apply the multiple doors? And maybe at some point they'll go through one door and want to come through the other, as he described. So I thought that was well said, and just being able to have these discussions, acknowledging our quote unquote failures to our population we serve, and how can we bring the voice forward and make us all better and better serving for our clients. And yeah, so thanks for that group chat. I'll pass it to Elisa.
Thank you, Rita. hear me?
You are breaking up a bit, Elisa.
I apologize. I'm having some speaker issues.
It's better now.
Okay, it's better now. Great. And maybe I'll start my video. So what I'll share is that, okay, so Dan from Watsonville Community Hospital, Keisha from United Way, Humera from Planned Parenthood Marmonte, and Monica from Encompass. And I think our conversation, was really a courageous one. Sharing from the hospital, there have been significant challenges with COVID around some of the planning that was underway. For instance, to open a new unit that would serve folks experiencing substance use disorder, as well as hiring of staff to really focus on that population. But there's real commitment, I would say, to moving that work forward. And from the Kaiser Permanente perspective, they've been really committed to Artery Council. That's been challenging. People is it breaking up? Okay, Stephanie, I'm going to send it back to you. I apologize.
Okay. It's funny when you're trying to confirm it's clear, but when you were speaking, it wasn't. It is 9 o'clock though.
Yeah.
And so I, thank you, Elisa and team, for facilitating this exercise. I really appreciate people's engagement and willingness to go. I think this is a great conversation to have and to continue. Just a reminder that the November HIPC is canceled and the annual board meeting takes its place. So our next HIPC meeting is on December 10th from 7:30 to 9 a.m. Thank you all so much.